Good afternoon, everybody. Welcome to another Thursday HiPAM. We will wait a few more seconds as we get everybody logged in, and then we'll kick it off. There we go. So for our new attendees, we typically have three sections: an overview, a Hawaii forecast, some science highlights, and then we do a deeper dive webinar. So we're happy to have Dr. Josh Quint, one of the epidemiologists within Disease Outbreak Control Division, to speak about Aloha Safe, as well as Michael Kamita. So thank you and welcome to you both. And at any time during the webinar, please put any of your questions in the Q&A chat and I will get to them as soon as possible, depending on where they apply. And with that, we're gonna go and get started, and we typically have more people trickle in. So welcome to another Thursday. As we always do, we start with Japan, and Korea will be starting next week, as we're gonna start to receive Korean tourists coming back into Hawaii. But for a while, towards the end of the year, we were concerned about any Japanese travelers coming to Hawaii and potentially bringing transmission. But as you can see, it's safe, knock on wood, to say that their trend down is pretty optimistic. We will continue to watch it, but once again, Japan's 7-day average continues to decrease down. Looking at a national overview, also as well, trending down, which is great news. In addition to vaccine distribution ramping up, though we are keeping a close eye out in terms of the variants and potential impact of that. CDC and Dr. Fauci have estimated by end of March that the UK strain will become the prevalent strain within our country, and still waiting to see how that South African strain will play a role in transmission within our country. For our 4 states that contribute to about 50% of our returning residents is also our tourism. Arizona trending, still continue to trend down, maybe a slight tick up, but once again, we like to wait a few weeks to see if there's any major changes in trends. California also continuing to trend down. Nevada and Texas, similar negative trends. So once again, positive news for us in terms of future risk in terms of transmission brought into our state by either returning residents or from our visitors. Moving on to our Hawaii specific overview, Maui unfortunately hasn't returned to a lower than 10 case per 100,000, but they're not far off. The rest of the counties are well under that 10 cases per 100,000 cutoff. For our percent positivity, all of our counties now are under that 3% positivity, and that's great news as we continue to move forward within our COVID response and COVID vaccination response. State of Hawaii is still within our phase 1B, our phase 1 Bravo. As of the most recent data pulled, 9 February, over 218,000 doses have been administered within the state, with an increased delta of about 8,700 from the previous day. And once again, they release a weekly summary in terms of their doses administered, and I believe that they haven't released it, they will be releasing shortly a breakdown in terms of first dose and second dose. So that's gonna provide increased granularity in terms of the progress that the state is making to get to some sort of herd immunity in terms of full vaccinations across our populations within the state. Testing turnaround time continues to remain at a high level, and hopefully so. For our newer members, the 3 pillars in terms of our public health response, continues to be contact tracing, testing, turnaround time, and also isolation, quarantine. And hopefully we won't have to lean too much to those 3 pillars. moving forward, but it's always good to see that one of our pillars is remaining strong. Moving on to our HiPAM forecast, our 14-day forecast, courtesy of the Brain Power and the Brain Trust within HiPAM. Based on a bunch of data points and metrics, we are continuing to forecast relatively flat for the next 2 weeks. Our red is our pessimistic, and our blue is more of our expected line and trajectory for cases. And then because it's flat for cases, subsequently, our hospitalizations and fatalities are going to mirror what our cases are going to be for the next 2 weeks. And then we do synthesize the CDC forecasts. They're the forecast ensemble that Levi, one of our core members, has incorporated onto our forecasting page. And on this slide, it's a similar information. It's just in a numerical format. And once again, for our new members, these slides are available on our website, hipam.org. Go to our top right corner and click on Join the Discussion, and you can see all of our archives for recordings as well as our previous presentations. Thanks, Josh, for posting that. I did not catch that updated information. I'll make sure that that's reflected in today's presentation. As continues to be the trend, there's always tons of data and information and papers that are coming at us every single day, let alone every week. So it's really hard to highlight everything, but CDC did update a few of their guidance, so I wanted to bring that to everybody's attention, as well as a paper that confirms what we knew from some of our MMWR case studies in terms of the importance of circulation and how that impacts transmission in an indoor setting. So as of yesterday, CDC updated some recommendations for our vaccinated persons. If you have gotten both doses of the vaccines, have at least 2 weeks after that second dose, and you are asymptomatic following contact with either a suspected case or a confirmed COVID-19 case, you are not required by CDC standards to quarantine for the recommended period. Now, notice that this does not apply to travel. We are waiting to see if CDC continues to take this crawl, walk, run approach and translate it to other other movements. But this is the first guidance we've seen from the CDC in terms of any guidance on fully vaccinated persons. So once again, this is the first of what we hope to see more guidance from the CDC. Second update released yesterday, more data to support the importance of fitting a proper mask. And they did do some study. They did have some data to support if you are wearing a surgical mask and you layer with another cloth mask, that does increase the fit and does provide increased protection up to 95% reduction, as you can see on the figure here, from potentially infectious aerosols. It is important to note that this study did not look at double layering or double masks of cloth masks or any other type of combination. So once again, important to note the limitations of the study moving forward. But most important, the takeaway is to have a really good fit for the mask. And if you do have a cloth mask that has double layering within it or has very tight weaving, then that's just as good as double masking as well. Finally, let me see if Itzvan is on. I know he teaches at this time, but for Lee and Tom and some of our other modelers, I found this to be great confirmatory evidence that it's not just how many people are in the room, but it's also the circulation. So in a paper published in AIP, Physics of Fluids, they just confirmed some data that really risk mitigation needs to involve not only mask wearing, but also proper circulation, ventilation, and also maybe putting up some barriers physically inside the the restaurant to make sure the flow, the airflow is such that it protects everybody indoors. I see. Jim, a question from Jim. Are any of the higher infection projections shown as gray other models on the HiPAM case graph due to inclusion or assumptions about the variants? So great question, Jim. So let me move back, and I want to make sure I save enough time for Josh to present the Aloha Safe. So let me just move backwards. I'll spend just a couple minutes on this. So currently for HiPAM's model, Jim, we haven't really factored in the variants. We're working on that, but Monique and her team have put together some scenarios that we're hoping to share maybe in the next week or so with the group. The hard part with the variants is we still lack a lot of information and insight for Hawaii's situation on how it's widespread this particular UK variant has spread, and also we don't have any confirmed cases of the South African strain. So it's really hard to change our assumptions based on this very limited data, but this is something we are closely monitoring and working with Marguerite and some of our state partners as well. So more to follow on that, but great question, and we'll be sure to update our modeling as we get more data. If there's no other questions from the group, I'm going to stop sharing and hand it off to Mike and Josh to present on Aloha Safe. And welcome to both of you. Thanks, Josh, and thanks, Mike, for presenting.
Great, yeah, thank you. Who is pushing the slides? I didn't know we sent them to you guys.
I can be your Vanna for today. No,
awesome.
No worries.
Oh, real quickly before we do that, I will mention the updates to the vaccine dashboard, because we did not wasn't just the data that was updated. There's some new features, or we can do that after at the end. Let's jump into Aloha Safe, and if we have time at the end, we'll do vaccination. Great, so it's great to be back. I think I presented a month or two ago on dashboards, and one of my other big passion projects is this Aloha Safe Alert exposure notification. You may have heard of it. It's been in the news over the past couple months, and it is available for download in the App Store. So we'll go through this presentation. The goal is really just to explain, help people understand how it works. On one level, it's very, very simple, and kind of like your computer or your car, under the hood, there's a lot going on. And so we're going to open the hood just a little bit, explain some of the back-end procedures and principles and theories behind this, and then have some time for question and answer at the very end. And I brought Michael Kaneda along. I'll introduce him a little bit more when we get to his part of the presentation. Next slide. So just a couple kind of overview key points that I want to talk about today. One is that exposure notification technology in Aloha Safe, specifically for Hawaii, was developed by the community and for the community. So public health and the health department has a sort of a central role in how it works. The technology companies have created it so that it cannot go along without public health. They want it to work in combination and coordination with health department public health activities. But that being said, you know, the health department is spread thin. We have emphasized our traditional methods, manual contact tracing, the tried and true, you know, decades, if not hundreds of years old methods. And this new technology has been viewed as innovative, a little bit experimental. And so we really relied heavily on the private partnership, people in the community like Michael, who will be presenting later, to help, you know, ramp up and provide the technical support, the technical guidance and capabilities to get Hawaii up to speed. And so, you know, could not have been done without them. And it is very privacy preserving. So that's a key feature of the app. I know that when I first heard about this concept of, you know, smartphones doing exposure notification and contact tracing, I had some skepticism. I thought, you know, all right, this is something that's going to come from Apple and Google and the government. Like, I don't know if people are going to go for that. And I think Apple and Google understood that and have built in many, many layers of security and protection to allow users to have confidence that their data is secure on their phone. it complements existing contact tracing activities, and I kind of mentioned that, but you know, it doesn't replace, it adds on to it, supplements. And so it also is in coordination with Department of Health. So one key feature of this technology is that you can't, a user can't just spam the system with fake diagnoses. They have to, there's a critical step of the diagnosis being verified as a real true case through Department of Health records. And Department of Health also sets thresholds for what defines a true exposure. And then we also provide guidance to the users through the app, CDC level standard guidance and also localized guidance, where to go for testing. So at every step along the way, DOH is involved. And one really great thing about this technology, it has the ability to reach people, contacts of cases that our traditional methods might miss. Next. Key point number 4 is that it is used by many states, over 20 states. Last time I checked, that may be higher now. And we have metrics that we're looking at that can help us assess, you know, the progress and the impact that it's having. So those are the key points, and kind of just the big picture is that the thought was this pandemic is happening. It's 2020 when the pandemic first hit, and we know about contact tracing from Ebola outbreaks. That was designed, you know, years ago, and now that smartphone technology is so ubiquitous, the thinking was, can smartphones help modernize the public health response? And that's how we end up with something like Aloha Safe. Go ahead, next slide. So you may hear there's a few acronyms. This one, GAEN, GAIN, it stands for the Google Apple Exposure Notification. And it's embedded in your Apple or Android device, and Google and Apple as tech companies really provided the technical capabilities and capacities. You know, we needed this type of function to be interoperable. It couldn't be just an Apple solution or a Google solution. And it was pretty interesting to see those two tech companies work collaboratively to make something that can work interoperably with both devices. It is anonymous, and the devices privately communicate with each other using Bluetooth. So rather than GPS or any type of location tracking, it's using a low energy portion of your Bluetooth to ping the other phones that are around you with gibberish codes, and then those codes can reflect, you know, your proximity to other people who are carrying their devices. So it measures the strength of the signal and the duration of the interaction to approximate your COVID risk relative to being near other people. Thanks. So how it works, the alert is triggered only if the minimum threshold of exposure is met. So we don't want to just have someone where you pass by for a couple seconds and, oh, now, you know, the app is going to tell you that you're exposed to COVID. We want it to be, you know, consistent with CDC guidelines of what they've defined as a close contact or a genuine COVID exposure. So the way that we set that threshold, or it's been set, is 6 feet or less between devices for a duration of 15 minutes or more while contagious, and that would be within the period of the last 14 days. So each of these parameters is important. Obviously, the phone doesn't know exactly where the 6-foot line begins and ends, but the strength of the signal over time can generate an approximation of, you know, what we think of as defining a COVID exposure. And then the 14 days is important because we don't want to store long histories of data, A, for space, but then B, for, you know, kind of that privacy consideration part. And, you know, we're not going to contact trace more than 2 weeks back. So it has a 14-day window of time that it stores the data on your phone, and that data can be used to help notify you of your exposure. So here's a visual of how it works. You can imagine a scenario where you're at some kind of gathering, and there's you on the top. Maybe a family member is there. Maybe there's someone who's like a friend of a friend who you never met before, so we'll call them a stranger. and then there's another friend. So in this scenario, you got 4 people, and 3 of them have the app as indicated by the icons there on the screens, and 1 of them doesn't. So let's see what happens next. All right, so I got infected somehow, and now this is maybe a couple days later. Let's say it's 1 day later. Those people who are at that gathering now would be considered exposed, and they should quarantine according to public health recommendations. But the question is, how are they going to get notified? Now, manual contact tracing says that my testing positive, my result will get reported to Department of Health, and Department of Health will call me, do a case investigation, and part of that investigation assess my close contacts over my infectious period and gather contact information for those close contacts, and that's standard traditional contact tracing. But what about this stranger over here? So the family member, okay, I talk to them, I let them know, I see them all the time. The friend, okay, he didn't have the app, so the app isn't going to alert him regardless, and maybe I'm able to give the contact tracer the friend's phone number, or maybe I just save the Department of Health some work and I just tell my friend directly, hey, you're exposed, you need to quarantine, here's the guidance. Well, that stranger, if I don't have their contact information, if I don't have a way to find them and reach out to them, then they have been exposed and they don't know about it. But because our phones were pinging each other the day before, now their phone has my gibberish codes stored on them, and then their phone is pinging a national server looking for codes that match that would indicate that they've been exposed. Next slide. So as each person's phone is pinging the national server looking for activated keys that match the keys that have been stored on their phone, if it finds a hit, then they'll get this type of alert. This would be considered an exposure notification. You may have been exposed to COVID-19 in the past 14 days. And so this is kind of the chain of transmission, the chain of notification, where it starts with one person being diagnosed, they have the app, and people who were in their proximity during their infectious period are able to be notified of their exposure. Next. And so this is just kind of more from DOH side of how the process works, and just sort of rehashing what I described through the pictures there. So you could think of it as 4 general steps. There's diagnosis, verification, notification, and quarantine. So in stage 1, the person has to have downloaded the app prior to their time of becoming sick. And then if a few days or weeks later, the app's been running in the background on their phone, accumulating keys and transmitting those keys, and if they get confirmed positive, well, DOH in step 2 has a list of all new cases that have been diagnosed in the state. And what we do is preemptively send a text message to all new diagnosed cases. So if you've been diagnosed in the past about month and a half, and the DOH had a valid mobile phone number for you, then you will have received a text message. And I'll show what the message looks like in a few slides. But we push out a text message, and it says, anonymously share your COVID result to Aloha Safe and help your community. And it's from Hawaii DOH. So in that message contains a URL that if you click, it will launch the app, and the app will then take you to the next screen where you're asked to provide your consent. So it's very important that we aren't generating exposure notifications without the consent of the user. And in addition to privacy, consent is a really big feature and principle of how the app functions. So every step along the way, consent is required. So you still have to confirm and decide to share your diagnosis. And if you do, within 48 hours, any exposures that fit the minimum criteria, your close contacts over the past 14 days will receive a notification that they may have been exposed. And a key principle here is it's that fit the minimum exposure criteria. And we do anchor the diagnosis to a date. It's preferably the symptom onset date, because that's the most reliable way to determine when someone was infectious. We'll go 2 days prior to when their symptoms began. That's when infectiousness really starts to ramp up. And so we want to look back, and it is that critical window, because if you're symptomatic and you know it, then hopefully you'll isolate yourself and avoid others. And we start to worry less about exposures during that period. It is that pre-symptomatic period that we do worry about a lot of potential exposures. People are still feeling okay, they're out and about doing their normal activities and potentially exposing others without their knowledge. And then there's also some known asymptomatic infections, and those people may also be transmitting. So if the person is asymptomatic, we will use the date of their test as the best approximation of when they were likely to have been infectious, and we'll designate a window. And so it's not all contacts that were within proximity over a 14-day period. It's just the contacts that meet the minimum threshold. So they had to have been too close for too long and had to have been within the infectious window. And that's really important for generating accurate notifications of true exposures. And then finally, the goal is that the person will quarantine at that point. So the notifications go out to the close contacts. They are instructed to self-quarantine and go find testing, and so they can know their status and take the precautions, monitor themselves for symptoms. And all these guidances come in through the app in a really simple, easy to understand way. Next slide. One question I've seen a lot from the public about that last step is, so if I get an exposure notification, does that mean I have to go into quarantine? And the answer is, we hope you'll go into quarantine. Part of the privacy preserving piece is that DOH does not know who has received an exposure notification. That's the anonymity, privacy, and the app cannot be used by Department of Health or any other authorities in any coercive manner to enforce, restrict someone's movement. So this is really about self-empowerment, about people having new information, more information about their COVID risk so that they can protect themselves and protect the community. So I'll stop there and hand it off to Michael, who will talk about some of the other features and dive into some of the app screens and what you can expect as a user.
Yeah, so also, if you can rewind one slide. So this screen has basically all of the other US states that are on board. I think it might be one or two more because this slide hasn't been updated yet. But basically half of the states have adopted exposure notifications apps. And so all of the positive keys are shared and downloaded. So there's interoperability for people traveling between any of these states running the apps. And people outside of these regions can still run the app. They just won't be able to verify their diagnosis without the cooperation of one of the participating health authorities. Next slide, please. Yeah, so this is what the new user onboarding screen looks like. This is just what you see when you start the app. The important thing here is that your phone is remembering the other devices it meets, but it won't identify you to anyone. Your privacy is protected because your personally identifiable information never leaves your phone, and then it's going to expose you or notify you if you may have been exposed to COVID-19. If you can go to the next slide, please. So here's a little more detail on how your privacy is protected, and this is available when you onboard. Essentially, the phone is frequently changing those random numbers. So not only are you sending out like random codes, those codes are frequently changing, so they can't be associated back to an individual. And yeah, you can move to the next slide. So this is some of the permissions that you have to consent to, and basically Apple and Google and the Department of Health get a surprisingly small amount of data in the interests of privacy. You can go to the next slide, please. So there, your setup is complete. You can go to the next slide. And so once you've opted in, this is what the dashboard looks like of the app. Ideally, this app can just run in the background on your phone, but if you wanted to, you could go to this dashboard and view up-to-date stats on COVID activity. And then if you expand out that stats thing in the middle and hit more, it'll go to a per county breakdown of recent cases. So you can move on to the next slide. So this is what happens if you are infected and you've tested positive, and you will receive that text on the left that essentially says anonymously share your COVID result. And if you click on that link, it'll open up within the app. It'll auto fill in the verification code and then ask you to consent to sharing your information. And all you're sharing here is those random codes that you've been sending out during the period that you were infectious. So, there's no location data and no personally identifiable information that you are sharing. Next slide, please. Another way to report your positive test is over the phone. You can request a verification code manually. You can go on to the next slide. Actually, skip ahead to, I think, skip this one, next one. So this is what the exposure screen is, the other screen on the bottom. So other than the dashboard is this. On the left, this is what it looks like if you have no exposure reports. And then that link goes to review health guidance, which pops open a Department of Health webpage. On the right is what you will see if you do end up with an exposure. It'll say, a rough estimate of when you were exposed. It largely because it doesn't want you to be able to know for sure when or where or who exposed you. So in the interest of anonymity, it's only giving you this somewhere between the 28th and the 30th. And it gives you a recommended quarantine period based on that, and then it advises you to reach out to your healthcare provider and take a test. You can go to the next slide. And so this is the exposure notifications onboarding. So these alerts went out yesterday and today and are going to trickle out throughout the rest of the month. And essentially, when your phone realizes, or when your phone knows that you are in Hawaii, and so that's if you have significant locations turned on. So that's not GPS. That's like if you want your weather app to know that you're in Hawaii, or something like that. So it's just significant locations. If you have that turned on and it detects you're in Hawaii, your iPhone will receive this notification saying that Aloha Safe or exposure notifications are available. And then it will prompt you to consent and to enabling it and turning on exposure notifications. And this is the sort of flow for that. So you may have seen that alert. And if you didn't, it is probably because you are on iOS 14.12 or 3 and need to update to iOS 14.4 or 5 or whatever the current version is. So next slide, please. So this is the sort of adoption timeline that we've had. So in June, we began working with the Department of Health and with Apple and Google on developing this system. In November, we did some pilots. In December, we expanded to some of the other counties. And then in January, we did our statewide launch. And then in February or yesterday, we did our Exposure Notifications Express launch. And Exposure Notifications Express is basically some of the Bear app functionality built directly into the Apple operating system. So, you don't get the stats dashboard and some of the customized messaging about what to do in the event of an exposure, but you will still be participating in the system and receive a notification. It is just a bare bones notification about, hey, you probably want to go get a test because you have been exposed or may have been exposed. So next slide, please. So here's our adoption metric. So far we have over 120,000 app downloads. It's coming in basically about 2 to 1 in favor of iOS, which is something that every state is seeing essentially, that Apple is coming in ahead in terms of app downloads about 2 to 1. And then Express enabling that because of that notification and some other things ends up with a lot of activation. So we have 92,000 of those. So we're currently at around 212,000 users, or approximately 15% of the population. Interestingly enough, the way that Express activations are counted, so because of the de-anonymization of the system, they actually count the amount of times that people see the logo that is displayed to you when you're at the consent screen. And then Apple estimates that about 0.7 of those people will opt in once they see the consent screen. So that's what they think that their click-through rate is, and we're refining this model as this has been going. Interestingly enough, when we asked Apple how they got that number, Apple told Josh he needed to stop thinking like an epi and think like a e-commerce marketer. And so that lets you know how much actual math comes behind some of those estimations. But the important thing here is that the Oxford did a study that was published earlier this week about the efficacy of England's app. And they essentially found that in their model, for every 1% increase in app uptake, there was a 0.8% increase in number of cases averted. So on the right, the x-axis is the percent of population using the app. The y-axis is the percent of cases averted. And then that red line is essentially a 0.8 slope. So right now we're at the far left of that, around 15%. And we, as people continue to download and use Express, we will see increasing efficacy of the app. Next slide. And I'm gonna hand it back over to Josh.
Great, yeah. So this is just to highlight the collaborative effort and support and partnership. It kind of emphasizing that this isn't super DOH heavy, and in terms of us like really pushing it and saying, everyone has to do this. We need to make everyone do this. It's more about enabling a tool and thinking. The analogy that's helped me a lot is the Swiss cheese model, because it's very easy to poke holes in this system. You can say, well, not everyone in the community has a smartphone or can use it or wants to use it, and on, and you can poke holes, but we're not expecting this technology to be the one thing that stops COVID from spreading. It's, as we've seen throughout this whole pandemic process, there is no one thing. It was at the beginning, it was wash your hands and stay 6 feet apart. Okay, that's a start. That's hard to do. Stay home, maybe. Can't do that for very long. How about masks and everything along the way? And we're seeing vaccine rollout now. You have situations where people may have had one vaccine, they may have had two, but it's not 100% effective. What about the variants? And on and on it goes. And it just emphasizes the need to layer on interventions to provide more cohesiveness and barriers to preventing COVID transmission. And so it's been a great partnership. We've had amazing support through private sector, through government, and through universities. Next slide. So, just kind of circling back and thinking about the journey that we've been on and how we've gotten here. Yeah, I'll say I'm very amazed. A lot of my skepticism from, early summer in June when these conversations were starting, I figured this would have to be, number one, extremely private, because I didn't think Americans, and some other governments and countries, they're able to mandate things like all citizens use an app. And, that's constitutionally not going to work here in America. And I think there's a fundamental distrust by segments of the population of anything that is government, anything that is technology, and sadly, anything that is science and medicine. So, I was skeptical that this technology could reach an adoption level that would become effective. And that skepticism has been met by, a lot of developments. One development was the accuracy, figuring out that Bluetooth can be a good proxy or indicator of proximity of people. We know that people carry phones around with them all the time. The signal attenuation and the experimentation that they've done in labs with having mannequins holding phones at different places, and having mannequins on like Roombas, kind of floating around and then validating. So the level of research and development that's gone in from Apple, Google, and researchers like at MIT and Oxford and Stanford has been very impressive to bring it from just an idea and as a concept to what is in operation now. The privacy, accuracy, and then efficiency. That, to me, that's the biggest selling point, is that, you know, it was first conceived as, oh, this is going to work hand in hand with manual contact tracing. And, you know, trying to layer in an experimental and brand new method and protocol, you know, is very problematic. So luckily, you know, Google and Apple have been receptive to that and generated things like Exposure Notification Express, and generated ways, the way that we're currently using is delivering codes before or without needing a phone call, because that could be a very rate limiting step. And a lot of other states that launched their exposure notification technologies earlier in like November, December, and experienced surges, they benefited from their population having this, because the growth curve of the virus can go exponential, and being able to train staff that can do manual contact tracing is not going to go exponential. And even if it does, it's not scalable. And so that was really, to me, a big selling point of this, is if we can make it efficient, make it scalable, then it's going to do some good. It's going to help people that are willing to opt in. And I'll just say also that, you know, it's only going to be as effective as many people use it. So I initially thought, well, you know, maybe we can't expect probably to get 50% statewide population, because I'm thinking of all the, you know, barriers, structural barriers to people downloading apps and doing phone technology, and just, you know, people have different comfort levels. So I started to immediately think of, well, what about subpopulations? You know, what about universities where you have people are very comfortable with technology, they use it in their everyday life. You know, if you can think of an epidemiological bubble, you know, I'm not really at risk of someone who's on a different island, not directly, maybe indirectly through multiple chains of social connections. But if we just think about it on different scales, you know, imagine if you and your friends and their friends are high adopters. Well, then this app will work in that population bubble. And so that's really one way to approach it. And another way is, yeah, just the more people that have it, thinking about visitors coming, that's definitely one of those kind of anonymous type of interactions that are going to be really difficult for manual contact tracing to catch up to. It's easy to identify household members, family members, close friends. You have good memory, you have good contact information for them. But for some of these more like casual interactions that could still meet the 15-minute threshold, like we see with tourists and visitors and things like that, you know, this app can really play a role. And then again, like I said, the efficiency. So just in summary, you know, this is efficient and scalable. It supplements, it can identify contacts that traditional methods may not reach. It's a great example of a coordination and collaborative effort across, you know, it's not just public sector, it's not just private sector, it's really a cooperative effort. And finally, I'd say the take home is that it's a tool that can empower community members to be better informed of potential exposure risks and to anonymously inform others of their risks. Last slide, I think I have one more. And I'll end. So Michael, I think, showed some of the data from this very, very new study that was just updated on February 9th, so 2 days ago. But this is some encouraging news, because what everyone in the epi public health community has been wondering is, does it work, right? It's great in theory, where's the evidence? And there's sort of this impasse or dilemma where, you know, people didn't want to commit until they knew it worked, but you can't know it works until someone tries it out. And so that, you know, different jurisdictions have approached it on their own pace, at their own timing. And some of the early adopting countries that had really robust systems that they built are now starting to look at their data, analyze it, and try to evaluate the effectiveness. Because if it's not effective, then, okay, maybe the system needs to be tweaked. We need to keep going back to the drawing board. And if it is effective, then we should try to encourage more people to use it. And so just some highlights of this recently pre-published study. So they achieved 49% of the smartphone users and 28% of their total population. They point out that this automates their contact tracing. And then they used two different approaches. One was with modeling, and one was direct statistical analysis of the empirical case data. And they found that it's somewhere between 0.8% and 2.3% reduction in cases or averted cases per 1% increase in app users. So it does kind of show that amplification process that the more people that use it, the more effective it can be. And that's everything we wanted to talk about, but I definitely want to make sure I saved 15 minutes at the end for Q&A. And I know one came up and that I wanted to answer live. So is there data on how many notifications have been sent out in Hawaii since Aloha Safe was launched nationally? So this comes from Jim Raymond. And it's a great question. It gets at that kind of effectiveness piece. How is it working? So you'll see, actually, can you go back one slide, Thomas? I think they mention it in here. They talk about the number of notifications distributed. There it is. The app sent 1.7 million exposure notifications, or 3.2 per index case, or 4.4 per index case who consented to be contact traced. So there's another kind of dilemma here with the data, which is different countries have slightly different systems. And so the UK set up their system to collect the data on the front end. The US has not, our systems have not been set up to identify the number of exposure notifications generated. That said, they are realizing that that's a big gap, and you can collect that data and still preserve privacy. There's a way. You ask for consent of the user up front, and you'll get this whenever you download a new software or program. It'll say, do you want to share the performance app data with the developer? And you either opt in or opt out. So we are going to start doing that for our app as well. Actually, it already asked for consent, and so that we will have the ability to get aggregated, anonymized, de-identified data just about how many notifications are being generated. But this is sort of in development still. We don't have the capacity to do it yet. We are tracking number of codes claims and trying to work on maximizing that. And we hope to get better data about number of notifications generated in the future. But in the meantime, we can look at the data coming out of other jurisdictions that have had more robust data collection in place and kind of extrapolate from there.
Yeah, a few other studies are finding, somewhere between that 4 and about, 6 notifications are sent out per person that consents to the system. And, that doesn't sound like a lot, but with the number of people that consent to manual contact tracing, they're only notifying, like 2 to 3 people per person. And that's a much slower manual process with a, individual actually phoning people up and trying to get a hold of them and all that sort of thing. And also takes a much longer time than this system. So.
And I'll say that it doesn't sound like a lot, but not a lot of people have a lot of close contacts during these COVID times. So especially that meet that minimum threshold, so that is what we do find a distribution. I think the median is probably around 2 or 3, and then there's definitely a long right tail of people that can have 5, 10, 15, but that's pretty in the minority. I saw Marguerite had a question and you answered it in the chat, Michael, but maybe just talking more about and you showed it on a screen, but just kind of connecting to EN Express.
Yeah, so if you want to rewind the slide, maybe 4 or 5.
Because that's the timing of this was really great, and that we've been preparing to launch EN Express for a couple months now, and everything
one more.
came together just yesterday.
Yeah. So the alert that you saw should have looked like the thing on the left, that exposure notifications are available, and this is part of that EN Express offering that we enabled, and which expands our reach down to iOS 12.5, and yeah, it just makes the onboarding process a little easier. You don't get access to the stats, and you don't get access to customized advice and guidance, but you do get to be part of the system. And these notifications will go out to anyone that has consented to receive availability alerts. I'm not sure how that works in iOS, but essentially most people running iOS, once they come into a region that has or is using exposure notifications express, they will get this alert. And so that's actually only United States regions right now. So for Japan, for example, has a different exposure notifications app.
Yeah, and that's going to be a great feature for Hawaii as we try to, start to reboot the economy during the recovery phase. There's going to be this sort of gray area where the disease like activity is starting to come down, but COVID will not yet have been eliminated. And we're trying to, gradually ramp up without risking another surge. And part of that is, the big role that tourism plays in our economy. And so having visitors that come in be, automatically notified about, hey, you can join exposure notification in the state of Hawaii in a very easy, opt-in, opt-out manner, will just be in one extra layer of protection.
Josh and Mike, thanks so much for presenting. I have a question, and I may have missed it, but I'm just thinking from an operational and to increase utilization. With so many people wearing smartwatches, either Apple watches, Samsung watches, Fitbits, etc. Does this currently apply to that, or is there thinking toward making it applicable towards those utilizations?
Yeah, it doesn't currently. There's like a whole separate Bluetooth hardware working group that's separate from the mobile phone consortium or whatever. So this effort was driven by Apple and Google specifically, and then it just happened to use Bluetooth. And so the Bluetooth manufacturers or trade groups or whatever they are trying to develop wearables that integrate with this system, but they're not there yet. Right now, it's only available on mobile phones.
Thanks so much. And then Marguerite has a question. Do you have any plans, or does DOH have any plans to have a video on incoming flights? This would be great to have with those State of Hawaii videos.
That is a really good idea. I'm not sure that we've talked about adding video roll. We are putting up posters and signs and things like that, though. And then we are working with the folks behind the Safe Travels forms, just to have, at the end of that form say, hey, thank you for filling out the form. You should also download this app. Here's a QR code that you can scan if you need to, or whatever.
Perfect. Any other questions for our two awesome presenters? Thank you again for taking time out to share. I think I already have it downloaded, but I think the more people we can get, especially as we get the vaccinations roll out, and potentially people may start to let their guard down, right, and not be as aware or tracking their locations like they used to be. Having a tool to help them remember moving forward will be useful, as well as the accuracy part. So someone in the chat.
Yeah, I'm dropping some links there. One is to alohasafelalert.org, where you can both find a link to download the app and FAQs, and there's even a supporter toolkit. So if you think this is a good idea and you want to promote and share it through your network on Facebook or Instagram, or I don't know if TikTok is a way, but there's materials there that you can share freely. We encourage that. And then also, if you wanted to see more on the Google side of how they've developed the technology and how it works, there's a great website there. And then I may steal the screen from you if there's other questions and talk about vaccine dashboard with the last couple minutes.
Please go ahead.
All right, so you're seeing my window. All right, is that showing, Thomas?
Yep, it's up on the screen.
All right, so yeah, major upgrade to what we had last time. So a few features to point out. It still demonstrates the supply chain logistics features with some cool icons here. So 309,000, there's a multi-stage process that happens. It's all sequenced out where the federal government, it's very, very limited supply right now, and they're allocating and distributing it out to the states in an equitable way. And so we can see the doses that have been made available for us to order, and that we order max out every time. And then those doses, they come on the way to Hawaii, they're shipped in, and so there's a lag there. And then once they're shipped in, they get distributed around the state to the different administration sites where they can go into ARMS. And then the data, refreshing. And then the data splits into two streams at that point. We have data that gets entered into VAMS, and this is the system of record for recording vaccine administration. It's developed by the CDC. It has some great features. It has some limitations, but we're working with it, and they are developing it with updates being pushed every few days and with feedback from users and jurisdictions. And then there's this side bucket where the federal pharmacy programs, they're sending and allocating doses directly to pharmacies like CVS and Walgreens to go into long-term care nursing home facilities and assist with the administration in those locations. And that data is not in the same bucket as the VAMS data because they don't use VAMS. And so the data kind of splits off, and these 17,444 doses, we do not yet have great visibility on the line level. We're working with the CDC to try to get that data at the line level, and we hope that they'll cooperate and give it to us. But in the meantime, what we have is the 201,000 doses that we can break down into first and second dose over time. We can see that the state is at 10.8% population progress of persons who have received at least one dose. And as the second dose number creeps up, so right now it's just at 48,521 because, you know, we just started vaccinating in mid-December with very few doses available. And as supply has ramped up, more and more people were able to get their first dose. But then they had to wait 3 or 4 weeks, depending on if they had the Pfizer or Moderna vaccine, before they became eligible to get the second dose. Some media outlets were reporting that there's mass people are declining their second dose. And while I would be concerned if that were happening, I have not seen evidence of that yet. We will be looking out for that. But I think what they did is they looked at there are 48,000 people that have gotten a second dose, and they either compared to the 153,000 first dose and said that's a big gap, or they looked back in time by a couple weeks and said, oh, you know, 3 weeks ago, 4 weeks ago, it was either 57, 85,000. And what's happening here is there's lag. So before we can find out about the dose, it's contrary to some rumors and conspiracy theories, the vaccine does not have a microchip in it, which means we don't know about it right when it goes into someone's arm. We know about it when the vaccination site enters it into VAMS. And some sites are really prioritizing just getting the shot into arm, and they say, we'll worry about the data later. And you can imagine me as an epidemiologist, I am trying to convince them that worrying about the data later is not a good idea. You should do it on the spot so that we can have more timely, accurate information to inform our activities and our response, know where the bottlenecks are. So, you know, it's a work in progress. We're working with our partners to get more timely data, but there is a bit of a lag on the most recent week. And that's a trade-off, right? People want the most recent data, and they want it to be extremely accurate and complete. And there are trade-offs involved with that. So we can have lagged data, which there's obviously limitations. We don't want old data because we want to know what's happening now. But if we show what we have exactly now available, then it's not going to be 100% accurate. So, you know, some second doses, we think this is definitely an undercount, as some facilities are waiting to do their batch entry of second doses. So what I would recommend is taking, you know, some of these prior weeks where the data entry lag will not factor in, and you can say that there were, for instance, let's see, as of week of January 3rd, 37,000 first doses were given. And if you fast forward 1, 2, 3, 4 weeks, there were 43,000 second doses given, which is higher than the 37,000. And that's probably because some people were eligible a little bit earlier with the Pfizer 3-week gap. And then some people were not eligible until this 4th week with the Moderna 4-week gap. So that's what we're offering. Also, you know, tracking closely the age. We can see we're going to be looking at the 75 and older population first to get as much progress done with them. And again, note that this is omitting the 17,000 pharmacy doses, which a lot of those are probably going to the 75 and older, but we won't be able to add them in until the federal partners give us that data. And then, you know, is kind of keeping an eye on this. For more information about the data, you can click the information link here, and it has a bunch of definitions and details to explain behind the scenes. Any questions? I saw something in chat.
Yeah, Josh, I think just Dr. Wu just put a thought out to help public understand lag between doses received and administered. If lag is about 1 week due to appointment time needed, et cetera, would it be any benefit of a metric, doses received 1 week ago over doses administered today, which is, I think, is this, kind of similar vein to kind of how to factor in kind of what you just pointed out with the lag calculation.
Yeah, so I've been advocating for that because I don't think it's fair to expect 100% administered out of doses that have been received to date. So I've been advocating for building in a lag, but when you tell people that you're lagging the data, they start to suspect that you're doing something nefarious. And so we just hope that we're going to show a gap, and that gap can be understood as a logistic issue, and not that there's just vaccines sitting around that no one's trying to give.
Awesome. Well, it's that time of the hour, bottom of the hour. Thank you, everybody, for participating. Look forward to having you back with us next week, Thursday at 4:30 p.m. Where I believe it's my turn to give a presentation. So, and it'll be more of an overview of where we started with HiPAM, and also the modeling efforts within the state and where we are today. So for our new members, and it's a good reminder of the great work that we've accomplished together in less than a year, although it feels like a decade since COVID hit us. But have a safe, long President's Day weekend, everybody, and we will see you next week, Thursday. Thank you.